Good morning, everyone, and thank you for joining us. Thank you for joining us. This is our number 13th CME for the year 2020. The first 3 CMEs for the year, which was COVID-19, diabetic foot, and SLE, the certificates are ready for download, those of you that have attended. The first 5 out of the next 10 will be ready by the end of the weekend, and then these last 5 will be ready by mid-December. Just to let you know, we still have 2 more CMEs left for the year. The schedule has not changed. It is the second Wednesday and the last Friday. However, we will forego the CME for the last Friday of December because it's between the holidays. And so our last CME will be on Wednesday, the 9th of December, and it will be a pediatric topic. Next Friday, we will have a special CME as we got a little bit behind this year because of COVID. And so next Friday, we will have our M&M, which will be presented by the emergency department. So you can join us for that. The feedback link will be posted in the chat, and the enrollment key is colonoscopy, all lowercase. And remember, all these CME meetings have been recorded and they are available on the university website to view and claim CMEs for those who would not have had a chance to attend the CME. And again, thank you to you, our audience, for attending, and to our IT guru, Dr. Halliday, who gets us started with a wonderful piece of music each time. Thank you very much, Dr. Halliday. So we will get started with our meeting, and our speaker today is Dr. Don Major, who most of you will know and remember from when he spent time here with us during his surgical residency. Dr. Major presently works in the Department of Surgery as a consultant, and he is a graduate of the University of the West Indies. He did his surgical residency at UWI Bahamas, and he became the first Bahamian to complete the UWI Bahamas surgical residency program. So well done and congratulations, Dr. Major. He completed his surgical oncology and hepatobiliary fellowship at the Tom Baker Cancer Center in Calgary, Alberta. He is presently a consultant surgical oncologist and hepatobiliary surgeon at the Princess Margaret Hospital. He is a member of the Society of Surgical Oncology and a member of the Americas Hepatopancreatobiliary Association. So thank you very much, Dr. Major, for joining us and speaking with us today. It's all yours.
Good morning. Can everybody hear me?
Yes, we can.
All right, I'll start by sharing my screen. And I would like to thank the organizers of this meeting for granting me this opportunity to present on this monthly CME. Okay, can you see my screen?
Yes, go ahead, Dr. Major.
Okay. So this morning, I decided to talk about a topic that has been presented to me twice in this year alone. And since I've completed my surgical training in 2015, I've actually encountered 4 Bahamian patients that have FAP, or otherwise known as Familial Adenomatous Polyposis syndrome, or FAP. And then they wonder exactly what is FAP or FAP. Presently, I have nothing to disclose. We're going to go through briefly the case, what is FAP, some of the clinical manifestations, how do we diagnose, the germline testing, screening, surgical treatment, surveillance, and finally the conclusion. So imagine that you're a gastroenterologist or even a physician that has sent one of your patients to see a gastroenterologist, and they send you back these pictures of a colon carpeted with polyps. You may see some blood in there. You may see something that looks a bit more than polyposis. What exactly do you do with this? And what do you tell the patient? That was the situation that we were faced with this year when we saw a 30-year-old female, relatively fit, who in August of 2020 requested an actual colonoscopy by her gastroenterologist. Prior to this, she was actually experiencing bloody bowel movements that were periodic in nature. And she noted that she underwent a fecal occult blood test, according to her, and this was actually negative. But after the death of Chadwick Boseman, otherwise known as Black Panther, she decided that it was time to ramp up her testing. She was the epitome of health. Young female with no known chronic medical illnesses, relatively fit, good BMI. She had no history of any weight loss, no change in stool caliber, change in bowel habits, no nausea, no vomiting. She had no family history of any malignancy at all. She denied ever drinking or smoking, and she's never had any previous surgeries or no medications that she uses or allergies to medications.
Dr. Major, I am very sorry to interrupt. Can you speak a little bit louder and come closer to your computer, please?
Okay. So when we did examine her, we noted that the examination findings were all relatively normal. Again, fit, middle-aged female, all the vital signs were normal. The abdominal examination was normal. And at this time when we saw her, we decided to defer the digital rectal examination as she had already undergone a colonoscopy. And the remainder of her examination was relatively non-contributory. She had relatively pedestrian-like lab work, just showed anemia of 10 and a mildly elevated CEA of 19. And if you can see, her colonoscopy findings in the top right of the corner showed that she had all of these polyps within her colon. And then there was this beefy red ulcerative mass noted within the sigmoid colon in this young 30-year-old female. They decided to send her on for some staging images as they biopsied this mass. And the CT showed that she had a lesion in the sigmoid colon with some pericolic adenopathy and no evidence of metastasis to the lung or to the liver. The pathology from the endoscopy actually did show evidence of adenocarcinoma of the sigmoid colon. Our assessment at this time was sigmoid adenocarcinoma with polyposis of the colon. So she came to see us at our surgical clinic, and it's here where we discussed her surgical options. Because she had polyps arising from the rectum extending all throughout the colon, the ideal choice for her at this time was a laparoscopic proctocolectomy with ileal pouch anal anastomosis, or IPAA for short, and a protective loop ileostomy at this time. We went through the pros and cons of this operation, and she decided that she would like to go ahead with it. Her ileostomy was also reversed 6 weeks post the laparoscopic proctocolectomy and IPAA. And for those who are not familiar with that, this is where we actually take out the entire colon as well as the rectum, and then we make a little J pouch out of the terminal ileum. And this now we join back up in a staple fashion to the anus. And we always give them a protective loop ileostomy to allow time for that pouch to heal up. And at 6 weeks, we reversed the ileostomy. And because she was a cancer patient, we actually placed a portacath. And she did relatively well from both these procedures. However, her pathology showed that there was a T3 and 2 adenocarcinoma of the sigmoid colon. And there were over 500 polyps noted throughout her colon and rectum. She also underwent genetic testing, which is positive for the APC gene mutation. Colorectal cancer is the third most common cancer in men and women in the United States, and the second leading cause of cancer-related deaths. Approximately 20 to 30% of colorectal cancer cases are associated with a family history of colorectal cancer or colorectal polyps. And approximately 3 to 5% of these cases are associated with identifiable inherited colorectal cancer syndromes. However, FAP and other polyposis syndromes actually only account for less than 1% of all the colorectal cancer patients. When we look at FAP, it is a disease of autosomal dominant inheritance. It develops as a result of a mutation in the Adenomatous Polyposis coli gene, or APC gene, which is the gatekeeper gene, and it's also a tumor suppressor gene, and this mutation actually occurs on the long arm of chromosome 5q21. Somewhere between 25 to 30% of patients actually develop de novo FAP, meaning that none of their other family members have any clinical or genetic evidence of FAP. And the incidence is documented in the ranges of 1 in 7,000 to 1 in 16,000 live births. So about 2.29 to 3.2 cases per 100,000 patients or individuals. Another factor is that individuals can have a clinical diagnosis of FAP up to 30% as well, and they have no evidence of any germline or genetic mutation in that patient that has FAP. It manifests equally in both sexes, and it represents, like I said, less than 1% of all colorectal cancer cases. The average age of onset of polyps is around 16 years, and this can progress to cancer by the age of 40 to 50 years with an almost complete penetrance, meaning that individuals with FAP, 100% of them are going to get colorectal cancer in their lifetime. When we look at colonic polyps themselves, and this is more for DM1 residents in general surgery, because this is a common question that they get in the pathology exam. What are colonic polyps and how do you classify them? So colon polyps are just mass lesions protruding from the intestinal mucosa towards the intestinal lumen. And they can be divided into neoplastic polyps, non-neoplastic polyps, or submucosal lesions. The neoplastic polyps are the ones that we commonly see, can either be benign or malignant. If they're benign, they tend to be one of three types. It can be a tubular adenoma, villus adenoma, or tubular villus adenoma. If they're malignant, they can be non-invasive or invasive. Non-invasive just being carcinoma in situ or intramucosal carcinoma, and invasive meaning that they've actually spread beyond the muscularis mucosa. Our non-neoplastic polyps are that of hypoplastic polyps, mucosal, juvenile polyps, Putsch-Jaggers, and inflammatory polyps. And our submucosal lesions round off the remainder of our polyps that can occur in the colon. FAP has hundreds to thousands of polyps within the rectum, colon, duodenum, and gastric mucosa. There are basically three types. There's the profuse FAP, where there are over 1,000 polyps. There's the classical FAP, where there are between 100 to 1,000 polyps, like what we had in our patient. Then there's the attenuated FAP, where there are less than 100 polyps. The polyps, like I said earlier, can either be tubular, villous, or mixed polyps, but regardless of their histology, the most significant risk factor for cancer with these polyps is the size. The bigger the polyp, the bigger the chance of it being malignant. In the majority of patients, polyps usually develop during childhood, and in the classical FAP, they tend to develop around the rectosigmoid area. And by the time they're adolescents, the polyps tend to be throughout the entire colon. And after that, they can increase in size and number. About half of the FAP patients develop adenomas by 16 years of age, and by 35 years, 95% of these individuals have adenomas. Majority of these patients, usually in the adolescent age group, they tend to be asymptomatic until the polyps are either large enough or numerous enough to cause rectal bleeding or even anemia. Some other complaints that they may have, and usually in keeping with individuals who can have a colon cancer, they can have change in bowel habits, constipation, diarrhea, abdominal pains, palpable abdominal masses, and weight loss in young patients. And this can lead the astute physician to send them for a sigmoidoscopy to identify any polyps that are suggestive of FAP. They also have extracolonic manifestations of FAP. And these can be seen in 50% of patients with FAP and can be used to screen affected family members. Those that affect the endodermal origin are adenomas and carcinomas that arise in the stomach, the duodenum, small intestine, thyroid, biliary tree, and finally the liver. They can be ectodermal in origin that cause epidermoid cysts, congenital hypertrophy of the retinal pigment epithelium, and brain tumors, which are normally seen in turquoise syndrome, which is another subtype of FAP. Can be arising from the mesodermal tumors, such as desmoid tumors, fibromas, dental problems, usually supernumerary teeth, and osteomas, which are usually seen in Gardner syndrome, which is another subtype of your classical FAP. Some of the intestinal manifestations, they tend to have polyps, like I said, within the stomach, and in about 90% of patients with FAP. However, these polyps rarely progress to any form of cancer. The lifetime risk of gastric cancer in these individuals with polyps is around 0.6%. When they do biopsy these polyps, they tend to show low-grade dysplasia. Surgery, however, is reserved for individuals with high-grade dysplasia or if there's any evidence of cancer within the gastric mucosa. They can also get polyps within the duodenum. That's mainly in the second and third parts of the duodenum or within the periampullary region is where they commonly occur. Again, these can occur in up to 90% of individuals with FAP, and they tend to occur around 10 to 20 years after the diagnosis of colorectal polyps. It's reported that up to 100% of individuals with FAP will get duodenal adenomas within their lifetime. These adenomas, however, have a higher risk of developing into a cancer, usually at around 5% of the patient's lifetime. And this usually occurs specifically around the periampullary polyps, and they can progress to cancer within 10 years. So for individuals who have FAP, they should be screened for these duodenal adenomas at the age of 20 to 25. When we screen them, we actually look at a classification called the Spiegelman classification that classifies the polyps into 4 categories: the number of polyps, the polyp size, the histology, and the severity of dysplasia. And the point system is given from 1 to 3 based on these 4 categories. Then we calculate their Spiegelman score and give them a Spiegelman stage. If they have no polyps, the Spiegelman score is 0, so we scope these individuals with the upper endoscopy at 5 years. If it's between 1 to 4 with a Spiegelman stage of 1, we will scope them within 3 to 5 years. 5 to 6, stage 2, we scope in 3 years. 7 to 8, stage 3, we will scope in a year. And if it's high, 9 to 12, and they're stage 4, we consider a duodenectomy or even scoping them at 6 months. And a duodenectomy can be done in the form of a pancreas-preserving duodenectomy, or if they have a periampullary cancer or a cancer invading to the head of the pancreas, then you'd want to do a Whipple operation in these individuals. Other intestinal manifestations is up to 70%, of these individuals actually get small bowel adenomas as well. What actually causes death in these individuals with FAP? The main thing is that of the colorectal cancer. Second is the desmoid tumors that they can develop. And finally, the duodenal cancers are actually known to be a cause of death in individuals with FAP. Recent data, however, suggests that gastric cancer is increasing in these individuals. What are desmoid tumors? These are histologically benign but potentially locally aggressive tumors. Over the lifetime of these individuals with FAP, approximately 8% of men will develop desmoid tumors and 13% of women will develop these desmoid tumors. In FAP, these tumors tend to occur within the abdomen, and they tend to occur near the superior mesenteric vessels, making it surgical almost near impossible. Recurrence rates for these tumors even after surgery are relatively high, and the overall benefit from resection is not clear at this point in time. Now, if they do develop a small desmoid on the anterior abdominal wall, and you feel that you can get a resection with negative margins, then that's warranted to go after and resect. But if it's involving the SMA and you could obviously damage these vessels, then that'll probably be something that you want to do something less definitive for. Also with these desmoid tumors, they tend to recur or they tend to occur after these patients have actually undergone a surgical procedure to remove their colon and rectum. And if you have a family history, a strong family history of desmoid tumors, then you may want to wait a while before you go in and actually remove the patient's colon and rectum, because now you put them at increased risk for developing the desmoids. We also have to be aware of thyroid cancer in these individuals, because up to 12% of patients with FAP will develop thyroid cancer. And the diagnosis usually occurs at around the age of 28, ranging from 12 to 62 years of age. So it's recommended that these individuals actually undergo an annual thyroid ultrasound exam for screening. When exactly do we start this annual thyroid ultrasound exam? The jury is still out on that, but it's something that you should be aware of in the FAP patient. Now, attenuated FAP, this is the less aggressive variant of FAP, and is characterized by having between 10 to 100 adenomatous polyps. They also have a later age in which these patients actually develop polyposis, as well as a later age in which these patients can develop cancer. Clinically, these colonic polyps usually occur within the proximal colon with infrequent rectal involvement. And these attenuated FAP can occur in families or family members that have the classical or profuse FAP type. And again, this is also inherited in an autosomal dominant pattern. MAP is a recessively inherited syndrome due to the biallelic mutations in the MUTYH gene. Again, this is another subtype of your FAP, where they have between 20 to 99 adenomas. So how do we diagnose our patients with FAP? As we say, they may be completely asymptomatic. So it's quite important that we get a detailed family history. And we want to look for any evidence of cancer, desmoids, or any evidence of any extra manifestations of this FAP in patients that from their grandparents, their parents, as well as their siblings. And especially if you have somebody that presents with a mandibular osteoma or even a desmoid tumor as their presenting complaint, this should actually lead to the workup of ruling out an FAP in this individual. A clinical diagnosis is generally agreed upon when there are more than 100 adenomas found, and you want to undergo germline testing for the APC as well as the MutH gene, which is recommended for individuals to facilitate screening of their family members, as well as it may be predictive in determining extracolonic manifestations of FAP. Prior to genetic testing, you want to get these individuals genetic counseling by a certified genetic counselor if available. Now, individuals can have a clinical picture of FAP and there not be any evidence of genetic mutation. Like I said, this can occur in up to 30% of individuals. Now, when a specific APC mutation has been identified in the index patient, all first-degree relatives carry a 50% risk of FAP and should be referred for genetic counseling and offered APC mutation testing. Now, if you have somebody that is the index case and they have this APC mutation and you test their first-degree relative, if they do not have the APC mutation, then you can effectively rule them out as having any evidence of clinical FAP. However, if the patient does not, the index patient does not have this APC mutation, then you cannot necessarily use that APC mutation not being available or not being in other family members as a way of ruling them out. You would actually have to undergo colonoscopic screening or endoscopic screening for all first-degree relatives for this individual. Some of the germline testing, we have recent development of the next sequence or next generation DNA sequencing and multiple panel testing that allows patients to be tested for all known colorectal cancer genes with a single blood test. A study done in 2012 with just under 9,000 individuals where the genes were tested for APC and the MYH mutation showed that mutations were found in 82% of individuals with over 1,000 polyps. And as you can see, as the polyp number decreases, the identification of these mutations also decreases. So when a patient is the first in a family to be diagnosed with FAP, genetic testing is indicated for that patient. Most authorities recommend testing at puberty because cancer is rare before that age. Combining data from 5 European registries of patients with polyposis showed that 0.2% develop cancer before the age of 15 and 1.3% develop cancer before the age of 20. A survey of 26 registries found 1 case of invasive cancer before the age of 17. You want to get a genetic diagnosis of FAP, and again, first-degree relatives of persons with a clinical diagnosis of FAP should all be screened for FAP. Screening begins at the age of 12. It's pretty young, but you want to get this thing early because you know colorectal cancer is their leading cause of death, and you want to get these patients prior to them developing colorectal cancer. And screening is usually in the form of a flexible sigmoidoscopy in individuals who suspect that have the classical FAP. And in these children or these young adults, you want to actually take samples of the suspected adenoma because lymphoid follicles could actually represent or look like adenomas within the colon. For those individuals without any evidence of polyposis, they should get examinations every 2 years. At the age of 16, they can have a colonoscopy performed, and if no polyps are identified, they continue screening up until 20, every 2 years, and then you can actually push it out to every 3, 4 years as clinically relevant if they have no evidence of polyposis. For individuals with attenuated FAP, screening begins at a later age at 20. The surgical treatment for these individuals ideally is that of a proctocolectomy with ileostomy or ileal pouch anal anastomosis. But the optimal timing of surgery should be individualized for patients. You want to take into account the educational, intellectual, and emotional developments of the patient and his or her reliability for follow-up evaluations. Some of the indications for immediate surgery, the absolute one would be that of documented or suspected cancer, or if the patient has significant debilitating symptoms. Some of the relative indications would be that if they have a significant increase of adenomas over time, or there's an inability to adequately survey the colon because of multiple diminutive polyps. There are usually 4 types of operations that we can offer these patients. We can remove the entire colon and leave the rectum in situ. And this is usually done for patients that have minimal polyps within the rectum, such as the attenuated FAP. We can do a proctocolectomy, where we remove the entire colon as well the rectum, and we can staple this anastomosis, or we can do a hand-sewn anastomosis along with a mucosectomy. And finally, we can also do a total proctocolectomy, and we give these individuals an end ileostomy at the end of the day. Should we remove the rectum or not? So some of the pros of leaving the rectum behind is that we avoid the deep pelvic dissection. We minimize the chances of these women becoming infertile because we know that fertility decreases by 50%, and we speculate that this is due to pelvic adhesions post-surgery. We avoid any urinary or sexual dysfunction. We avoid the increase in bowel frequency that these individuals experience with the ileal pouch anal anastomosis. We avoid the risk of incontinence, and we avoid an ileostomy. But now, who should we remove the rectum in? Obviously, if there's rectal cancer present, or these individuals have high-grade dysplasia, if there's a large rectal polyp burden, so they have more than 20 adenomas, or they have large polyps within the rectum, then you'd want to actually remove those rectal. And if they also have more than 1,000 synchronous adenomas, these individuals should have their rectums removed. If they have poor sphincter function, or if they're incontinent, then it's not recommended that you do an ileal pouch anal anastomosis for these individuals, because you will just turn their perineum into a stoma. So these individuals ideally would want to give an end ileostomy to. If they have a distal rectal cancer that's involving the sphincters and you have to take the sphincteric complex, again, these individuals should get an end ileostomy. And if you want to avoid the functional limitations that some people experience with the ileal pouch anal anastomosis, again, these individuals can get an end ileostomy. Once surgery is completed and the patients have recovered, they still have to undergo post-surgical surveillance. They would still need yearly endoscopies of the rectum, if it was left in situ, or the ileal pouch, because there's an increased risk to actually developing rectal or pouch adenomas, especially 7 years post-surgery. If they've had an end ileostomy, you want to examine this every 2 years just to make sure that they don't develop any ileal polyps at that time. We also have drugs that we can use for chemoprevention for individuals with FAP and adenomas. These drugs have been shown to minimize or decrease the amount of adenomas and not necessarily decrease the risk of cancer though. However, there are no FDA-approved drugs for this reason at this point in time. But we still can use one of 2 COX-2 inhibitors, such as sulindac or celecoxib, to give these patients to minimize the amount of polyps that they have developing. Finally, diet and lifestyle changes. Caloric restriction or diets with olive oil, fruits, and vegetables has significantly reduced the number of polyps genetically in genetically manipulated APC min mice model. Again, diet and lifestyle changes is something that has been shown to minimize risk of developing of most malignancies. So it's something that can help individuals who are diagnosed with FAP to try and minimize the chances of them developing malignancy. So in conclusion, FAP makes up less than 1% of all colorectal cancers. These individuals should undergo a detailed family history in order to determine who is at risk and who has FAP. At-risk family members should undergo routine screening endoscopies. Prophylactic colectomy is the treatment of choice during late teens or early 20s, and continued screening is necessary for associated cancers. Thank you. A few references that I came across.
Thank you very much, Dr. Major, for presenting that unusual diagnosis to us. So just to let the audience know, you can post your questions in the chat. But Dr. Major, we will start off with one of the things you highlighted during the presentation, that it represents less than 1% of colorectal cancer. So why did you choose to present this topic to us today?
Again, great question. Again, because like I said, at the end of 2015, when I completed my training, I had seen maybe 2 patients with it. And then again, this year when I got home, again, another 2 patients with it. The first patient that I didn't present was that of a young lady who was only 26. And she had a complicated appendicitis that required her to undergo a right hemicolectomy. And during this time, we noted that she had all these polyps within her colon. So we ended up sending her off for a colonoscopy. And due to COVID, she had gotten kind of lost to follow-up and represented just about a month ago with small bowel obstruction. We took her in to relieve the obstruction, but at that time, she was noted to have metastatic disease throughout the peritoneal cavity. At the age of 26, with 2 young kids, that kind of hit home for me. And then again, we had this young lady, 30, that was having rectal bleeding. You know, most people chalk that up to say, okay, you're 30, change your diet, it's likely hemorrhoids. And she being persistent with it, she was able to undergo a colonoscopy. And at that time, she already had a T3 and 2 colon cancer. So it's something that I feel that we should always keep in the back of our mind for individuals who may present with some rectal bleeding and want to get that detailed family history, not necessarily send them, all of them for endoscopies, but if you get that detailed family history with respect to colon cancer, you may be able to find that 1% that has, you know, this FAP mutation. And again, for these individuals who we've actually identified, going out now and testing their families, their first degree relatives, and making sure that they themselves do not have the genetic mutation or they themselves do not have polyposis is somewhere that we can actually take this going forward.
Okay, thank you. And our first question comes from Dr. Tracy Roberts. And she wanted to ask about the patient that you presented. Was the patient staged via CT or PET? And did she have upper GI endoscopy?
She was staged via CT scans. And CT scan of chest and abdomen. And this is where it showed that she had the T3 and 2 lesion within the sigmoid. Nothing was in the chest or within the liver. We kind of tend to use the PET CT for individuals, you know, who we suspect have indeterminate findings, let's say within the liver or the lung, and she didn't have either or. So we were happy with the staging from the CT scan. All right. And her second question was?
Upper GI endoscopy.
Yeah, she did She did, however, undergo upper GI endoscopy, but I don't think there were any polyps that were present at that time. But she will continually undergo this via her endoscopist that discovered her colon cancer and polyposis.
Okay, and we have a question from Dr. Marcus Cooper. What are the complications with IPAA? Forgive me, I do not know what IPAA stands for.
Oh, it's ileal pouch anal anastomosis. So it's the anastomosis that we do in individuals who actually undergo a total proctocolectomy. And it serves as a reservoir, because we've removed the rectum now, so it serves as a reservoir to kind of minimize the frequency of stools when these individuals actually have to go. Some of the short-term complications related to that would again obviously be leaking of the anastomosis, hence why we place our proximal ileostomy to minimize leaks and allow for this to actually heal. So with the proximal ileostomy, the short-term complications tend to be minimized. Now, the long-term complications would be that of stricturing of your pouch. And now patients can actually present with abdominal discomfort, abdominal pain, nausea, vomiting, or they can get something that's called pouchitis, which again is inflammation of the pouch. And this can be debilitating in some patients, but it's found that pouchitis occurs more commonly in individuals who have ulcerative colitis and they undergo a total proctocolectomy, as opposed to individuals who have FAP. And finally, you still have to survey this pouch because, like I said, up to 7 years later, individuals can develop polyps within the pouch. And if any of these become cancerous, then you may have to go back and resect that pouch and give them an end-ileostomy.
Okay, thank you. And so you answered one of the other questions, which were short and long-term complications of the IPAA. And so our next question from Dr. Deval Roll is juvenile polyposis the same as FAP?
No, juvenile polyposis is actually a different entity. And the polyps within that they tend to be of the non-neoplastic type. FAP tends to be of the neoplastic type, such as the tubular villus and the villus adenomatous. So it's a separate entity.
Okay. And Dr. Claire Miller, is it challenging approaching parents re the frequent screening required for such young children?
I suspect it is a challenge, but again, if the parent has gone through what the child is going through, or the parent has been diagnosed with colon cancer at the age of 30 or 25 or whatever age it is, and they know that their child is at risk for developing this colon cancer, I'm sure that they would be more inclined to try and assist with the children getting their endoscopies. Again, another thing that I kind of pointed out too, if the parent has an APC gene mutation, you can test the child now for this APC gene mutation, and if they don't have it, then the chance of them having polyposis is next to zero. So they would not need to undergo colonoscopic evaluation.
Okay. And from Dr. Bassett, as this is familial, are there certain Bahamian names that are associated with the condition? Like the surname Johnson is often associated with polycystic kidney disease in the Bahamas.
I'm sure there are, but again, I think someone like Dr. Monroe would be more knowledgeable about that because he's been around and he's seen a lot of these things since he's been here. But I can't say the exact name associated with the FAP. I may have to discuss that with him.
Okay, thank you. And from Dr. Raleigh Butler, was there any MSH6 mutations present, as she may also be at risk of a gynecologic malignancy like ovary and uterus? Hence, oncofertility will be important in this young woman.
Well, again, when the genetic testing came about, she only had the APC gene mutation. She had 2 other mutations of undetermined significance at that time. So we didn't come across the MSH6 mutation, no.
Okay, thank you very much. And congratulations, Dr. Major. This is from Dr. Conville Brown on quite an erudite presentation. Welcome back.
Thank you.
And so if then, okay, I see another question just popped up in the chat. It's not really a question, it's more of a comment. It's from Dr. Marcus Cooper. It would be great if Surgical Oncology Service could start a registry of these FAP patients and their families. It's very difficult to follow them in the public system. And I agree
I
with that
totally
also.
agree. Yeah.
And on that quest or on that comment, are you aware of any information that exists as far as the Bahamas on FAP?
No, I didn't come across any information in my Google searching, to be honest. Yeah.
Okay. Well, thank you very much, Dr. Major. We don't see any more questions in the chat on presenting a rare diagnosis, but highlighting the importance of taking a family history to elucidate who might be at risk. Dr. Brown, great presentation. Can you mention the youngest child with FAP?
Again, can't necessarily talk to that. I'm not entirely sure who's the youngest child with FAP at this point. I said probably have to kind of discuss that with Dr. Monroe because, like I said, he's been around much longer and he probably seeing this in the younger kids. Sorry about that, Dr. Brown.
But what about in your training when you were abroad? Were you exposed to any young children?
I didn't do any pediatric training per se. So no, I didn't necessarily come across any young children with FAP.
Okay.
Yep.
Well, thank you very much, Dr. Major. Do you have any closing comments you would like to leave us with?
Well, again, just to kind of reiterate what you said, and taking a detailed family history, especially for individuals that present, young individuals that present with these rectal bleedings or symptoms that may be related to any form of GI pathology. And outside of that, thank you for allowing me to have this opportunity to present here today.
Okay, well, thank you very much, Dr. Major. Thank you to your audience. Remember, you can do the feedback, which is the link is posted in the chat, and the enrollment key is colonoscopy, all lowercase. There are 2 more CMEs left for the year. We will have a special CME next Friday, which will be an emergency room M&M. And our last CME for the year will be a pediatric presentation on Wednesday, the 9th of December. So